Another way, also, where you can have loss in fluids used to resuscitate is in trauma. So if you have someone that's losing, especially during the first portion of the resuscitative portion in trauma, someone comes in and they're losing blood and their blood pressure is low. A lot of times, the initial part, if you're looking at trauma resuscitation, and they're talking about hemorrhaging type 1, 2, and the excessive part, the first few replacement that's done before you get to blood is usually fluids. So at times in trauma, you might see lactated ringers used during that. If you're in a trauma center, a lot of times they're using the lactate ringers as the replacement fluid initially. And the lactated ringers are similar to IV fluid. It is an IV fluid. It's similar to normal saline. However, it has an additional ingredients. I think they said sodium lactate, and additional ingredients, and some calcium in order to replenish the loss that you're having due to the trauma. And just as we discussed the loss of fluid due to vomiting and diarrhea, right? So things are pouring out. So if you think of a jug, the jug is now losing and the volume and the jug is going down. For vomiting, it's on diarrhea. That's how you're losing it. For trauma and bleeding, you'll lose it that way. So, not all traumas are bleeding on the outside. You can have internal bleeding, which I
That was going
have
to be my
blunt trauma.
question.
Yes, absolutely. So, how does one get internal bleeding? For example, if someone in a motor vehicle collision, an MVC, and they have blunt trauma to the abdomen. Because in the abdomen, we have organs that two large organs that are high risk of having you lose a lot of blood in a short period of time, which is the liver and the spleen. So if you have a liver laceration, so the liver is cut or smashed, then you're bleeding, and the bleeding will be internally. The similar that occurs during, like if with the same with the spleen. So during a trauma evaluation, during the first part of the evaluation of the trauma patient, especially if the vital signs are abnormal, the heart rate's elevated, and if the heart rate's elevated and the blood pressure is low or starting to get low, then you're evaluating the patient quickly for loss of blood, especially if you're not seeing it externally. And one thing that you might see in your in the documentation is what's called a fast exam. So, so the fast exam is the ultrasound. So in a fast exam, they're using the ultrasound machine to look on the abdomen to see if you can see signs of bleeding. And you can do that quickly at the bedside without moving the patient from the room to the radiology department. Especially if you're concerned that the patient might be unstable, you don't want to move them and then have them coding in the radiology because that's never a good thing. So
Okay, gotcha.
you could do so you'll do the exam, the ultrasound, and that's called a bedside ultrasound exam, and you can do it really quickly in like less than 3 minutes. You can get that done. And what you're doing is you're looking at the right upper quadrant and you're looking for signs of bleeding between the recess of the liver and the capsule of the liver. So you really between looking at between the liver and the kidney, there's a recess there. And if you see blood in there at all, then you can, based on our training and based on studies that have been done, know that at least 500 cc's of blood has been um, accumulated within the abdomen if you are seeing it on the ultrasound. So you can
Okay.
imagine, right? We have 6 liters, so you're really losing 500 cc's. So you're gonna you're gonna start to resuscitate, and the first set of resuscitation would usually be fluids. So that's one way. Why, so you might thinking like, well, why is the person using fluid? Why don't they just get blood? Blood is not usually that easily accessible. IV fluids, you can get that in a matter of a minute or so. Blood, you'd usually have to get it from the blood bank, and it has to get, if even if you're getting type O, blood, you still have to physically go and get it, as opposed to IV fluids are right there. And that's why the IV fluids will be the first set of resuscitative um, fluids used, and then blood afterwards.
Got it. And if I think about this and vet me, give me a
Hmm.
grade. If I think about this, so in the concept of like medicine, then diluted blood moving is still better than not having blood, because you said fluids are first point of it. So if I'm bleeding in the abdomen, I'm not, whatever blood is going where it should be going via the blood vessels instead of leaking out, I guess, into whatever structures, even
Hmm.
by, in my mind, and that could be wrong, diluting it and or putting giving saline allows movement and perfusion to in organs. Is that accurate?
Correct. So even diluted, yeah, correct. Diluted blood until you can get the whole blood is better than no blood, because when you think about the hemodynamics or the flow of what's going on, easiest way to think of is that you have a pump, and the pump needs to just keep getting fluid in so it can push fluid out. So fluid in to fluid out, and the pump is the heart, right? So fluid coming in, we need fluid coming in, and we need fluid going out. If you have a leak somewhere, which is what occurs like for the type of trauma that I just mentioned, that blunt force trauma, that person's liver or their spleen, they're bleeding out from that area. So we're having a leak in the system. So the blood or fluid going in, we're starting to have a reduced amount of fluid going in because there's a leak in the system, right? So the amount of fluid going into the pump is starting to get less. And then so if the amount of fluid going into the pump gets less, the amount of fluid coming out of the pump is going to be less. And then the amount of fluid keeps going lower and lower if we don't add fluid to the system. So adding fluid to the system is really trying to replenish the volume that's being lost by that leak until you can really get the whole blood, which is usually the whole blood is better because it has all the nutrients, and then all the factors that helps with clotting and to reduce the body from going into the shock state, which is DIC. That's what whole blood does. But in the interim, we need volume, and whole blood is a better volume than IV fluids. But as I mentioned prior, it's harder to get the blood immediately. So there's still a leak in the system. And so while we're getting the blood ready, we need to fill the pump. We need to fill the system because the volume is going down. And that's why you're given the fluids.
Got it. Got it. That's
Hmm.
beautiful. I love it.
Hmm.
So, this is a really great place to pause. Take home points on this lesson are lactated ringers and normal saline are different. Both can be used, but more often, lactated ringers are going to be used as a blood replacement in trauma. That was probably the golden moment for me. In my mind, I can't say, and even when I started the series of these videos, I said excluding trauma when we see fluids, not immediately associating its utility in trauma. Look out when coding for the ultrasound results. So if you can't get a final diagnosis, like it's definitely ruptured, you might look to your R codes for abnormal symptoms or abnormal findings of diagnostic imaging of the abdominal area. Check your evaluation and management section under examination for constitutional and notice the patient's heart rate as well as the patient's blood pressure. This is where, when we don't have a final diagnosis, we can paint the picture diagnostically in the form of symptoms, which often fall into your R code category in ICD 10 CM, and tell the story to justify critical care. An important note, it's not uncommon for us to have unsuccessful critical care, meaning patients who the providers have definitely done the work, done everything that they could, but at the end they weren't able to save the life of that patient. So we may not get a final diagnosis until the autopsy's done. And again, in the ED, we don't code from autopsies. We really have to code based on what's in our emergency room record. And the emergency room record is only going to speak to the information that was available at that time. So this is where, again, the symptoms and symptomology will be important for you to paint the story, to tell the story of critical care. In our next series, we're going to talk about the use of fluids in the condition known as sepsis. So stay tuned and look out for part 3 on my channel. Until next time, I'm Doris the Coder signing out.